So without further ado, we're going to get started. I wanted to briefly give you a synopsis of Structural Heart Program, and I couldn't really think of any better introduction than a quote by Mark Twain, is that I didn't have time to write a short letter, so I wrote a long one. The topic is very, very, very large, and the challenge is to try to concise it in such a short fashion. So please bear with me. We're going to try to cruise through some of the topics. So these are some of the stuff that we want to take home. What is structural heart disease? What should I be looking for in my practice as colleagues in the primary care arena? And how can these therapies, what are the therapies and how can these therapies help my patient? And when should I, the most important question is, when should I start referring to patients that need that care? You know, cardiologists and interventional cardiologists have been described as the China of medicine because we stuck our head in pretty much every territory. But I mean, with that being said, we share a lot of the experiences with our colleague from vascular surgery, IR, and CT surgery, and we have these great collegial relationship that we can all learn from each other. And as interventional cardiologists, our core is the coronary artery disease, but a lot of us have invested in the science itself, and the guidelines and the societies is now are merging together to invest in other territories other than coronary disease, because as we all know, that atherosclerosis is not a one vascular territory, and certainly it's not a one subspecialty, because everybody adds to the table. And it's really an honor to work with colleagues from vascular surgery and CT surgery and interventional radiology to tackle this disease. One of the newest, I should say, frontiers of cardiology or interventional cardiology is the structural heart disease. So what is, if we want to define it, structural heart disease really is defined as the complex pathologies that involve aortic valve stenosis, mitral valve stenosis, paravalvular leaks. Those are the valves that were placed by our surgical colleagues, and 10, 15 years later, the suture line dehisces, and now they have a severe leak around the valve. I can tell you the surgeons are not happy to go and operate on those, the cardiothoracic surgeons. So these are the patients that end up really in the arena of structural heart disease, where we can percutaneously offer them therapy. And then, of course, also extends into the PFO and the Watchman, and I will be touching briefly about the Watchman to cover the area that Dr. Islam was to cover, but I know my good friend Steve will be talking about ASDs and PFOs. So by definition, aortic stenosis is a restriction, the opening of the aortic valve. I'm not going to belabor this. This kind of is a narrowing of the aortic valve, and what results from that is the flow dynamics that causes ventricular pressure and then thickening of the ventricle, and as with time goes by, failure of that left ventricle and the symptoms of heart failure. Not to mention the arrhythmias that can be associated with it, and the ischemia from the coronary artery disease due to the supply-demand mismatch that happens in these thick ventricles. When we deal with aortic stenosis patients, this is one of my patients, is a 68-year-old female with severe AS. You can see the height and the weight. Past medical history is significant for hypertension, diabetes, morbid obesity, congestive heart failure, you know, the whole laundry list of what we see in those patients. We normally calculate their score based on their Society of Thoracic Surgery, and that is a number that we give these patients to determine if they are at a low risk, intermediate risk, or high risk, which then determines the mode of therapy for their aortic valve, whether it's surgical or percutaneous. Severe aortic stenosis, in general, by definition, in order to require therapy, has to be severe. So we don't really treat mild and moderate, right? And those are the criteria by echocardiography for severe. And that's why, because the higher the velocity across the aortic valve, the higher the mortality. And we'll talk more about that in details. The second thing that has to be provided or available in the patient to be offered the therapy is they have to be symptomatic. So the word severe, symptomatic has to be in the description to be offered TAVR or aortic valve implantation in general. And why is that? Because we know from the famous article that was written by Dr. Eugene Braunwald, who's one of the godfathers of interventional cardiology, that the aortic stenosis has this long latent period. And this could last about 10 to 20 years. But then at one point, symptoms starts to occur. And the mortality at that point of time, you can see how the Kaplan-Meier curve takes a nosedive. It's about 50% over the next 2 years. So everybody knows that severe aortic stenosis, asymptomatic, you got time, but then once they become symptomatic, the clock starts ticking, and we got a 2-year mortality of 50%. So that's when the therapy for aortic valve starts. In terms of therapy, there isn't much role of medical therapy in this disease, unfortunately. We talk great things about statins and beta blockers and ACE inhibitors and antiplatelet therapy for atherosclerosis disease. But when you have a valve that is tight and severe and stenotic, there's no medical therapy for it. There's nothing you can do for it to open up, other than physically opening up, either by replacing it surgically or placing it percutaneously. I can tell you the surgical AVR has been a great therapy. It's been around for probably 100, 150 years, maybe longer. And it's well established. It relieves symptoms. It improves survival, improves LV systolic function. It does have a morbidity that has incremental increase over the next every year by 2%. And certainly those who end up with a mechanical valve have the long-term commitment to anticoagulation. So that comes with a little bit of a price. So you can see that a good 40% of the aortic stenosis patients are not met by the surgery. So these are a lot of patients that are sitting out there that have severe aortic stenosis as symptomatic. They're not offered surgery for whatever reason, because their risk of surgery is too high, and these patients are just waiting for their natural prognosis to succumb to the mortality of 50% over the next 2 years. TAVR has been a therapy that's been great, and I've been involved in interventional cardiology in 12, 15 years, and I know interventional cardiology history goes beyond that. But we live in the era of vascular surgery and interventional cardiology with these advancements of technology, but I can tell you, and I'm living through some of these, or even my mentors live through the majority of these, they're always gratifying. But by far, from a personal experience, the most gratifying technology advancement today is TAVR. Because to me, and again, I'm a biased guy because I'm a structural guy, but I'm sure there's, not to belittle any other advancements such as EVAR, which has really moved the treatment for aortic aneurysm tremendously. But speaking of aortic valve stenosis, these are patients who come in, they get the valve done, and they go home the next day. There's no 3 months rehab, there's no open heart surgery, there's no sternotomy, and there's no morbidity and mortality that associated with this. Now, it has its own morbidity and mortality, but the gratifying feeling of the patients coming in with severe symptoms, can't walk to their mailbox, and the next day they're up and walking in the hallways is just priceless. There's 2 valves that are on the market, and we'll talk about this briefly. But really, the treatment of TAVR, or transcutaneous aortic valve implantation, has been spread over a spectrum of what we call what we call risk. That risk is measured by the STS, the Society of Thoracic Surgery, a stroke model that's been adopted across the many, many years and has been replicated and proven to be efficient. And those, based on that score, patients can be subclassified into 4 categories, either extremely high, high, intermediate, or low. And when the TAVR technology got adopted in the arena, it started off testing it against surgery in these categories. Now, the first category that the TAVR was tested is in the extreme high. Those patients did not even get surgery. So there was no need to randomize these patients. These patients were just offered TAVR versus medical therapy, and we know the results is going to come out pretty clear that these patients will improve survival and improve morbidity much better than the guideline-directed medical therapy. And I'm going to talk about some of these risks briefly. This is one of the trials that talks about the Edwards. So the highest risk, which are the inoperable, is patients that were included with TAVR versus medical therapy, and then less than the inoperable would be the high risk. And you can see the data in the Kaplan-Meier curve. Very summarized. I'm not going to belabor the point, but you can see in the high risk, this was the inoperable risk, where the yellow is the standard therapy, and then the TAVR is the blue. This is mortality. And then you can see it in the high-risk population that the 2 curves overlap. This is the randomization in high-risk surgery versus TAVRs. And we'll use that term SAVR and TAVR interchangeably, just so you know. So SAVR is for surgical AVR, and TAVR is for transcutaneous. And then the partner trial is the same, was followed up even out for 5 years. And you can see the 2 curves parallel out to 5 years. So it's not just a 1-year benefit. All strokes are parallel. And one of the things that was challenged is how durable these valves are. And this graph really shows it, among other graphs, that the echocardiographic features of these valves that are measured by gradients and velocities and durability. You can see that the both curves or both sets of valves, the surgical and the percutaneous, have similar functionalities out to 5 years. So it's a very durable valve. I'm briefly going to talk about the other product in the market. This is the Medtronic product. Again, it was studied in the inoperable risk and in the high risk, and you can see a replication of what we saw in the previous valve. Then they studied it in the intermediate risk. And the intermediate risk, again, patients were randomized to surgery versus transcutaneous aortic valve implantation. And you can see the curves, again, I don't want to belabor the point, but you can see the curves overlap. And the whole purpose of these studies was to show one thing, is TAVR as equivalent to surgery? And that's all the message that we wanted to get. And in these trials, that message and that hypothesis was proven to be correct. And then here you see it in the, finally, the low risk, which is the last of the frontier. This is the fourth, sort of like the fourth pie of the 4 pie patients, the inoperable, the high risk, the intermediate risk, and the low risk. Just recently in the ACC, American College of Cardiology, in March, the low-risk trial were published. And again, it was a win for the TAVR that is as equivalent. In fact, in one of the devices, which is the Edwards, actually was superior in the low risk to surgical. Again, this is the same thing that for the low risk for the Medtronic. Replicating the same durability out to 5 years, and you can see, 2 years in the low-risk Medtronic valve. Again, you can see the functionality, the functional features of the valve remains the same, whether it's transcutaneous or surgical. Things to keep in mind with these procedures that have some nuances to them is pacemaker implantation. Now, that has been higher inheritedly in the TAVR population. Again, this is a little bit higher with the Medtronic. We don't see that much pacemaker implantation with the Edwards valve, but also contrast that with the onset of atrial fibrillation. And we know these post-op patients have a very high risk of atrial fibrillation versus atrial fibrillation post-TAVR is very significantly less. And then finally, the other thing that's been kind of criticized against these trials or these devices is how much are you trying to squeeze in a circle into an oval shape, and how much paravalvular leak do you get versus the surgeons have the advantage of suturing the valve right into the annulus. And so the paravalvular leak has been another Achilles heel for TAVR, but the more technologies have been available, there's been some skirts built around the valve that seals those crevices that sit between the annulus and the valve, and we have less and less paravalvular leak. And in this trial it doesn't show that the paravalvular leak, exactly what the number is, but it does show you that clinically, if there's a paravalvular leak, there isn't need for aortic valve repair or another surgery. So in conclusion, after 5 years in the PARTNER 1 trial, which is the high risk, this is a 1A because the 1B was the inoperable risk. And then this was randomized to SAVR versus TAVR. Additionally, in the intermediate risk in the PARTNER 2 trial, and this was, again, 2-year data. And more recently with the low risk, we see the repetitive theme of no significant difference between TAVR and SAVR. And that is in all-cause mortality, that is in stroke, that is even in their symptomatology of the New York Heart Association class. Again, we also see a repetitive theme of no deterioration in the valve technologies. These valves perform as good as surgical valves out to 5 years. 10 years, 15 years, who knows? Well, as far as we know that, and data actually from Europe coming even out 8 years now that shows that they're durable. But at least in the United States, we only have data out to 5 years. And then finally, the paravalvular leak is a concern. It's still an Achilles heel, and we don't like to walk away with anything more than 2+ aortic regurgitation. We quantify how much paravalvular leak is there, and if there is a 4+, meaning the highest, and 2 and 3 and 2 and 1, 1+ or 0 has been okay, but anything higher than that has been associated with poor survival. So we always like to post-dilate and maybe put another balloon inside the valve and extend the valve a little bit further, and mostly we'll end up halving that leak to almost non-existing. but you don't want to walk away with a higher paravalvular leak because that's been associated with poor survival. So today, there are multiple categories of risks in patients with aortic stenosis. The extreme risk, TAVR, is preferred. There's a group of patients that I always try to discuss, and we in Covenant Healthcare, I was fortunate to be offered a fellowship training at Henry Ford, and then when I came back, I did a fellowship training in structural heart disease, and now I run the medical director of the structural heart programs. But we do have a bi-monthly structural heart programs, and we sit surgeons, interventional radiologists, and cardiologists, and invasive and non-invasive. And we discuss every of these cases, and the idea is to share thoughts and also to identify those who will benefit, and also, more importantly, identify those small group of patients that are futile. There is a group of patients that you can't offer them anything. Even those extreme high risk, yes, we take them on, but there's this little old lady who's 92, 93, she has home oxygen, she's on end-stage renal disease. I mean, come on, you have to kind of at one point draw the line. And if you don't have that decision in your practice, that's when you get burned. And we don't, the goal of all of us here in the room is to do what's best to our patients and not try to push the envelope more than the indications are. So there is a group of patients that unfortunately have no other solution. It's a smaller group. Now, back into the risk stratification, the intermediate risk, those are the 10%. It is acceptable. And then also in the high risk, and then finally in the low risk, I just showed you the data from March of this year that are not yet, however, we are now, can say, not yet FDA approved because the data and the papers have been published, and is expected at the end of quarter of 2019 that the low risk will be approved by the FDA. I want to just touch base on a very interesting topic also in terms of transcutaneous access. So how do we get to the heart? We get to the heart through the groin, and this is the whole gist of the TAVR procedure. You can get through the aortic valve through a small incision in the femoral artery, and you put a suture in, and the patient goes home the next day. Not all patients have beautiful looking arteries, right? Where we've been talking and hearing all the pictures and seeing all the pictures about atherosclerosis involving the iliacs. So there is a specific number that these iliac arteries have to accommodate in terms of their sheath size. And there is more advanced your patients are, the more advanced the atherosclerosis disease is. And there are going to be patients you're going to run into, or we're going to run into, that have severe peripheral vascular disease that cannot be offered surgical AVR, and they need a TAVR. And there's this, now people are now explored other options, we call them the alternative access. And these are some of the examples of the alternative access. You can go obviously transepical, which was one of the first methods adopted. You can go and make an incision. The surgeons would make an incision through the apex and get into the valve backwards. Or you can go transsubclavian, and we've had some experience with that, going through the left subclavian, preferably than the right. Or you can go transcarotid. And in Henry Ford, I co-authored a paper, and it's actually in press right now. We've done 36 transcarotids, but you need the surgeons to be comfortable with this. And again, I want to say one of the most beautiful things about this procedure is the harmonious dynamics that you see between the interventional cardiologist and the CT surgeon. This is a therapy that truly, truly is offered by both experts. And CMS have recognized this. All the billing has been adopting to that, and this is a hybrid approach. This is not a one-man show. This is not a unilateral decision. And the surgeons are true partners in these procedures. And then the one thing that I think is very exciting is this transcaval, and I'm going to just touch base briefly on this. This is a paper that was published by Adam Greenbaum, one of my mentors at Henry Ford. Wonderful guy, very innovative. What they thought about is how do we get to the heart, not through the artery, and get to the aortic valve, not through the artery, but through the vein. And if you think about it, somebody tells you this, you look at them, you're like, what's wrong with you? You have like three eyes, or there's no way you can get to the aortic valve from the vein. Well, some people are very innovative, and what they found that if you go through the IV, through the inferior vena cava, through the femoral vein, getting up into the inferior vena cava, and at one point, the inferior vena cava and the aorta run parallel to each other. And there is this retroperitoneal space, which we cannot ignore. But it was studied in animals, and now they had a registry, and it was published that it was found that if you can burn a wire through a cautery and put the wire horizontal in the IVC and have a snare waiting for it in the aorta, you can then burn out the IVC into the retroperitoneal space, into the aorta, and then snare the wire up into the aorta. And now you have a rail of wire from the femoral vein through the IVC, through the aorta, into the aortic valve. Now, the million-dollar question is, what do you do on the way out? So stay tuned. So you get in there, and now you expand the sheath. Now you get in from a wire to a 2 French to a 14 French, and then you get to the size of the sheath you want. You finish your TAVR case, nothing to it. You cross the valve, boom, boom, you balloon the valve, and you're done. On the way out, there's that AV fistula that you created. And they found that needs to be closed, obviously. And using an ASD device, which we'll hear a lot about from my friend Steve in his talk, that is a device that has 2 discs, and they're kind of pulled together. And if you deploy one side of the disc in the aorta, and you pull it back, and you deploy the other side of the disc in the IVC, now you have sealed that aortocaval fistula. And there's been a lot of data about this that have showing the safety, and it's now an FDA-approved method as an alternative access for TAVR in those who have severe aortic valve stenosis. Severe peripheral vascular disease. And this is a diagram showing the depiction of it. You can see the blue is the IVC, the red is the aorta, and you can see a catheter coming from the IVC, traversing into the aorta, and then on the way out, that is closed by the ASD or a VSD fistula, a VSD device. So 4 questions to remember. Does the patient have aortic stenosis? What is the patient's risk profile? What is the annulus size? All these patients get a CAT scan. They get a very dedicated TAVI CT to look at the size of the annulus. You got to get that size right. There's no room for error here. And if you put a valve too small, it embolizes. If you put a valve too large, you can dilate and rupture the annulus, and the patient is dead on the table. So a lot of thoughts is put into the sizing of the annulus, and also a lot of thoughts from the CT is put in the sizing and tortuosity of the iliac arteries. So how do you determine the STS? So when we get a patient with TAVR or with severe aortic stenosis, we obviously calculate their STS score, and these are some of the variables that play a role in that. And then you can plug that into the computer, and you come up with a number. That number is what determines your inoperable, high risk, intermediate risk, or low risk. And there's certain cutoffs. So this patient has a number of 8.6. Now, think about it. This patient just had a CAD or prior CABG. That number is now 11.2. So that puts one piece of information and moves the patient from one category to another, from a high risk to an inoperable risk. Anything above 10% is inoperable. In summary, aortic stenosis and TAVR is approved. TAVR is approved for aortic stenosis for extreme risk, high risk, and intermediate risk. It is yet to be approved for the low risk. The data just was published. And number 2, the TAVR, again, has been shown to have similar outcomes as TAVR in high risk and intermediate risk. TAVR should not be considered in these clinically futile patients. And then more to come about the low risk and the management of asymptomatic patients. I want to shift gear quickly and talk about Watchman, and then maybe we can open the floor. I don't think we'll have time to talk about the mitral. Again, the Watchman is a device that's offered to those patients who have atrial fibrillation, who cannot take anticoagulation. Now, I'm sure all of you are thinking, nodding their head, I got a few patients who are like that. Patients who have GI bleed, patients who have hematuria, patients who are at risk of intracranial bleed, patients who are at high risk of falls. Now, these patients we know who have atrial fibrillation needs to be on anticoagulation because of the risk of stroke. And those are the patients that we don't know what to do with. We kind of push the Coumadin and hope for the best, and then if they bleed, we stop the Coumadin and again hope for the best that they don't stroke. And a lot of times we don't have a solution for these patients until the Watchman device was approved. So briefly, AFib is a large population. It's going to grow. I can tell you it's expected to grow even more in the next in the 2025. There's about 5 million patients. The problem with the AFib patients is usually they have major strokes, and it has to do with the size of the thrombus. And also The atrial fibrillation results in a greater disability, again, major stroke, and a higher mortality. This is the reason why the stroke happens. This is the left atrial appendage, and you can see there's a big clot sitting in the left atrial appendage waiting to take off the left atrium into the mitral valve, into the aorta, and into the cerebral circulation. That's why atrial fibrillation patients, if they have a CHA2DS2-VASc score, this is a specific score that you're all familiar with, of 2 and above, should be on anticoagulation. That's the guidelines across the board. 1, you can make a judgment on it, aspirin versus nothing. And if they're 0, you really don't need to anticoagulate them. But the majority of your patients are going to be in the 2 and up. Now, anticoagulation comes with a price, and this is the price, right? This is the intracranial hemorrhage. This is a transformation of a prior ischemic hemorrhage. So hemorrhage is a big price that some of our patients unfortunately pay. And for that reason, and multiple other reasons, this is where today's real world is. Anticoagulation is only used in about 60 to 70 to 50% of the population. A lot of your AFibs now out there are not getting anticoagulated for whatever reasons that are listed over here. Either it's bleeding risk, cost effective, especially when it comes to the NOACs. Patients don't believe in it, patients' compliance. There is a good portion of these patients that are not treated. And again, the issue of discontinuation is not just with Coumadin. This is the discontinuation data of rivaroxaban, apixaban, the dabigatran, the edoxaban, and also comparing that to the warfarin. About 30 to 35% of the populations discontinue their anticoagulation for whatever reason. So there's an unmet need for these patients who either cannot take anticoagulation and obviously have a very high risk for stroke. The Watchman has been the therapy offered for these patients. So this is what a Watchman device would look like. It's a small clamshell, or you can call it jellyfish, or whatever you want to call it. It looks like a little a fabric in the surface and has little prongs towards the end. And what it is basically has been studied in those patients who are at high risk for bleeding in a randomized fashion. And I'm going to just briefly just show you. You could probably fast forward some of that video. You know, this is a catheter going. This is what the Watchman looks like when you deploy it. You can just skip forward some of that. It's a long video. Thank you. So here now we're getting. Now, how do we get into the left atrial appendage? Again, it's the beauty about the IVC, right? It's the beauty about the venous. We love venous access as vascular surgeons, interventional cardiologists, because it's a low-pressure system. You put your finger on it and it stops bleeding. So you get into the inferior vena cava from the femoral vein, you get into the right atrium, and you create a hole. We actually poke a hole in the intraatrial septum and get from the right side to the left side. It's called transseptal puncture. And once you get into the left side from the right, now you're facing left atrial appendage. There's different nomenclature for the left atrial appendage. Some of them are called chicken wings, some of them are called broccoli. And believe it or not, I've learned this, that everybody, just like everybody has a different thumbprint, everybody has a different appendage in terms of morphology. So the device gets put in, and then you can forward through the rest, please. And then you can go towards the end, and then the device gets deployed. And then before we release it, we make sure it's anchored, and then usually after 3 months, the device is endothelializes. Next slide. This is some of the data that supported the or paved the road for the Watchman device. This is the PROTECT data, the randomized PROTECT and the randomized PREVAIL, and then the continued access that happens after both randomization. And there has been some early on learning curve that you can see it here in the PROTECT AFib. The safety events were as high as 10%, but you can see as the learning curve got overcome, now the risk is now 4%, and actually in real world today the risk is about less than 2%. I quote my patients: there's a risk of 2% in this procedure, and that could be an accumulation of venous injury, tear into the left atrium and pericardial tamponade, infection, the stuff that you quote your patients with these procedures. But 2% is the overall national risk at this point, given the real world data. And in this trial, they looked at the PROTECT trial. You can see that these are the free from major bleeding events. This is where the device makes its impact. I could tell you the best day for our patients is when they come in on that 45 days. So we put the Watchman on day 0, they come back at 45 days. They still got to take the Coumadin for 45 days because the risk of clot formation on the device is still a risk. So these patients will get the valve, will get the Watchman, they'll come back at 45 days, we'll do a TE. And that's the day that the patients will look for. And that's the day you will tell the patients, you don't need the anticoagulation for the rest of your life. And the benefit of this obviously is going to be the bleeding risk because the stroke risk is the same. You can prevent stroke with Coumadin, you can prevent stroke with the Watchman, but you don't bleed with Watchman, you bleed with Coumadin and the NOACs. And you can see it here in the results that you can actually see a 71% drop in the bleeding risk in the red and the purple bar compared to the blue bar, which is the Watchman. So who gets the left atrial appendage closure device? Patients who have atrial fibrillation on oral anticoagulation, has a CHAS-VASc score of 2 or more, who have a clinically good reason. This is the wordings that's in the white paper, clinically good reason. And whatever that is a discretion of the referring doc that you feel that the patient has a clinically good reason to come off the anticoagulation. And some of that wording has been extended into a job hazard. So the firemen, the policemen who have atrial fibrillation and their job puts them at a risk of getting injured and the bleeding from the anticoagulation. Those patients are now being approved for the Watchman device. I will stop here for the sake of time, and I'm happy to take any questions. Thank you for your attention. Again, Omar, thank you for the opportunity. So how long you continue the anticoagulation after the Watchman? The protocol states by the FDA is a 45-day Coumadin, warfarin, and aspirin. And then at 45 days, you stop the warfarin if the TE shows no clot formation. And then beyond that, it's aspirin and Plavix. Actually, in the trial, the PROTECT trial, that was strictly followed with the anticoagulation, there was a 2% risk of clot formation on the device while they're on warfarin. So that's why we would do the TE to determine if they're among that 2%. And if that's the case, then the Coumadin will be continued on for 6 months. If not, then that's the day they will stop the Coumadin.
Did you repeat that again or not?
Yes. That particular patient, it's 6 months to determine. Every time you want to get to a point to stop the Coumadin, you got to get a TE because that's when they tell you, because clot formation on the face of the device has been reported in 2% of the population in this study.